Hello and welcome to this edition of Ask Your Doctor. I'm Dr. Alan Thornhill. I've been working in the field of IVF for over 25 years in a variety of different roles, starting as a clinical embryologist in the lab and now providing support and guidance for patients as a fertility coach. This evening, I'll be your host for what's going to be another interesting session, and I think the last in the current series. But remember, you can always watch them again on catch up. And we're covering a very interesting question tonight. When should I consider egg donation? This issue comes up time and time again in this webinar series. And while it's not the most common question I'm asked by my coaching clients, for many of them, it may be the question they need to ask, but perhaps they aren't yet ready to. I'm joined tonight by a fantastic set of panelists who are here to help you better understand when should I consider egg donation. And they are Dr. José Antonio Domínguez Arroyo, Medical Director of IERA in Portugal, a returning doctor, Dr. Ernesto Bosch, Medical Director of IVI Valencia in Spain, and Dr. Athanasios Garavelas, Director and Founder of Garavelas Medical Group in Greece. Now, I'm going to start by asking our panelists to introduce themselves and their clinic with an emphasis on what they offer in terms of treatments, diagnostics and services, with a focus on treating older women and egg donation, because that's the subject for tonight. Then we'll get right onto your questions. So please put them in the Q&A box rather than the chat, and then it'll be easier for me to get through them. And I'll ask the panelists, please, whenever possible, even though the questions are often quite specific, try and generalize them and try not to use too many acronyms and specific terms. We'll try to answer all of the questions, but I will prioritize ones that are easy to generalize, haven't already been answered, and stick to tonight's topic just in the interest of time. So without further ado, let's go on to our first doctor, Dr. Domínguez. Can you please introduce yourself and say a little about your clinic?
Yes, of course. I'm José Antonio Domínguez. I'm a Spanish doctor. I work in Badajoz. It's a little city between Madrid and Lisbon, but we have a clinic in Lisbon too. We started working in fertility in 1998. Since 2000, we have a overdonation program. We have the different law in the two different countries, so we can talk about the difference in the two countries. I hope to give something interesting for the women who are listening to.
Okay, thank you very much, Dr. Domínguez. Dr. Bosch, would you like to say a little about yourself and the clinic, please?
Of course. Good evening, everyone. It's my pleasure to be here today. I work in EB Valencia, probably one of the largest fertility clinics in Europe, and maybe one of the first ones. Indeed, we are celebrating now our 35th birthday. So it's a large experience, and doing egg donation since 1993. And still quite an important volume of our activity and treating patients coming from most countries in Europe and even from overseas. And I'm particularly working in EV since 25 years ago and became medical director in 2010. And yes, keep going with all patients coming from everywhere.
Lovely. Thank you very much. And welcome back. Dr. Garavelas, could you please introduce yourself?
Yes, of course. Good evening, Alan. Thank you for the invitation. I'm Dr. Garavelas. I'm one of the founder of Institute of Life, a Greek IVF unit based in Athens, which is inside the biggest maternity in private hospital in Greece and maybe in Europe. We perform several thousands of IVF cycles and 14,000 of births per year. And of course, we have the door is very, very open. We can offer egg donation programs, surrogacy programs, IVF programs, rejuvenation programs, everything in this hospital. That's all.
Okay, thank you very much. And I think Dr. Domínguez already, kind of set the path for us in talking about, there might be differences in different countries. So we haven't got too many patient questions in at the moment, so let's start with that, and we'll leave Dr. Domínguez for Portugal. I know you're Spain too, but we've got
Yes.
to talk about Spain. So if you can say anything about Portugal in terms of availability of egg donors, any specific laws that make it easier or more difficult than other countries, just sort of overview of egg donation in Portugal, please. And then we'll come to the other doctors too.
Well, the law in Portugal changed in the last few years, and now the anonymous is not allowed in Portugal. So the donation is non-anonymous, and they have changed a little bit the profile of the donors. Maybe we have less donor now than before. Even there is a country where the donation is not so common, like in Spain, for example. But now the profile is a little bit different, and we have less donor than before. And maybe in our case, we have some patients that want to come to Spain to do the donation because they prefer the anonymous status.
Okay, perfect. Thank you. I just want to pick up on one point. I mean, I am personally interested in this because I used to work with the HFEA, the regulatory body in the UK. You said there are fewer donors. Do you think that's directly related to the change of law regarding anonymity, or
a series of factors? Our story in Lisbon is not too far, but we started in 2016, but at that time the law hasn't changed yet. And after that, most of the other clinics I have talked to said that the availability of donors was bigger before the change of the law.
Okay, yeah, no, that's really interesting because I think a similar thing happened in the UK, but nobody really wanted to acknowledge that it was related to that law change. They kind of said it was to do with other things, but I was pretty convinced that that was a big factor. So thanks for that. Dr. Bosch, can you talk? I mean, Spain is very well known for egg donation. Can you talk a similar sort of overview? Maybe talk about the percentage of cycles, egg donation versus own eggs, because I know Spain does a lot of egg donation.
Yes. Well, first of all, in Spain, also there have been some changes in the legislation that are doing things, making things a little bit more restrictive, mainly regarding the number of cycles that the donor can do. In the recent past, the limitation was the number of babies that were born from one donor, but now the limit is being on the number of cycles that are performed. So this is not dramatically, but slightly reducing the availability because obviously the number of overall cycles that you are able to do is slightly lower. Having said that, well, the proportion of egg donation cycles that the clinic does depends very much on the setting. In the public setting is small. In the private sector is much larger. And once in the private sector, I would say that large cities and more with better communications to other countries are doing more egg donation cycles proportionally, and this applies basically to Barcelona because its proximity and its communications makes that egg donation there is very big. In Valencia, in particular, we are doing egg donation involves 25% of our treatments of our cycles, our egg donation cycles in Valencia. That means last year we did around 750 egg donation cycles.
Okay, perfect. Thank you. That's really helpful. Dr. Garavelas, can you give us a sort of overview of your experience or the clinic's experience of egg donation, please, in Greece?
Yes, in Greece, I think the law is very similar with the Spanish law. We are it's with anonymous donors. The age limit is until 50 years old and can be requested in the Ministry of Health until 54 for egg donation for IVF treatments. in our clinic, I think we are in 15% of egg donation, respective of the IVF on cycles, and approximately 20% of our cycles is from abroad. That's all.
Okay, thank you. And that's really helpful because you've added another dimension which does come up almost in every single session, about age. And that, that is going to link to the topic tonight, because I'm going to be asking you, not right now, but I'm going to be asking you, is age a determinant for, it's specifically a determinant for considering egg donation? But first, let's just go in reverse order again. Dr. Bosch, can you remind us, please, about the age limits in Spain for using your own eggs and using donor eggs, please?
Yes. Well, there is no specific legal limit in Spain. Spanish law speaks about age of menopause, which is a little bit blurry. But in practice, this comes to something in between 50 and 52. That's the limit for any ART treatment. But of course, when speaking about own eggs, we know that beyond 45, 46 maybe, we know that chances are really null beyond that age, and that's why, well, still some cases are performed and some patients that insist, but it's very exceptional. But in the case of egg donation, it's quite frequent that we're treating patients in the age range of 45 to 50. And well, exceptionally, we can do treatment to some patients around 51. If, of course, general condition has to be really good, no concomitant pathologies, no really, strong obstetric risk factors. That's really very well controlled in order to at least, it's always a risky pregnancy, but at least make sure that patient has not specific risk factors before you're going ahead. So that's basically how it goes. In general, although the limit is not established by legally, the Spanish Society of Fertility, the age limit of 50 is what really sustains, and what I think I'm quite sure to say that most practitioners are sticking to that limit.
Okay, perfect. Thank you so much for that answer. Dr. Domínguez, is it similar in Portugal, or what's the age situation in Portugal?
Yes, it's similar, but in Portugal, it's not allowed above 50 years old. So this is impossible. We can do above 50 years. But in Spain, as Ernesto have told, we can do even above 50, but we have an agreement, some kind of agreement between clinics to not to do above 50 years old, because it's a little bit dangerous for the women. So I think it's a protection measure. But in Portugal, we have a limit.
Okay, perfect. Thank you so much. That's really helpful to kind of set the scene. Now, we have got a couple of questions from the same person. I'm going to start with their second question because it's more general, and I think it might be more useful. I think it's probably worth asking each of you this, because I don't think it's like a fact-based question. This is more of a, what would you do for a patient who presents like this? So let's switch things around in the order. Let's go to Dr. Garavelas first and ask the question. Someone with recurrent implantation failure, and I know we could argue about how many cycles that means. This patient has definitely had multiple transfers. I just don't want to get into all the detail just yet. I want to just, let's consider it, we're confident it's recurrent implantation failure. How many cycles using their own eggs would you do before switching to egg donation, or would you go straight for an egg donation cycle?
No, we're not plan to start egg donation program, but what I mean recurrent implantation failure after euploid embryos, after 3 euploid embryos in transfer, or not.
Okay, so
if we already check the endometrium, we see the microbiome, we see if there is any infections, if there is any endometritis, and okay, what about the sperm also? We must see 360 everything, and then, of course, to tell to this person, to this couple, the options and the realistic statistic to proceed or to have other treatments, maybe PRP injections in the endometrium or SVF that we perform in Greece, or is it time to change the plan and go to the egg donation? But not at the first time. Then the first choice is they're willing to stay and to create with her own materials. We must analyze everything in 360 and then to talk about the step 2 and the plan B, that will be the donation.
Okay.
It's not the everything egg donation can resolve.
Sure. Okay, that's really good. Thank you. That's a very helpful answer. I mean, I purposely didn't give you lots of details, not to trip you up, just to kind of, to see what your response would be. But I mean, I can see from what's written, obviously I can't know what's not written, but it doesn't look like PGTA was done. And this patient's, I think, had their treatments in Germany, or they're from Germany anyway. So PGTA, as far as I know, would probably not be done in Germany. And I don't see any information. Yeah, and I don't see any information about endometrial testing, but I do see lots of transfers. But if they're not tested, so 11 transfers at least.
Yes, but Alan, when we talk about blind transfers, maybe and the other colleagues, they know Germany is not the first country for the IVF treatments. They perform only standard things. I think the medicine here in the IVF and the reproduction is in the tailor-made, is personalization. Of course, we must analyze everything 360 and then to proceed. So in our case, we must evaluate more what kind of embryos, what kind of endometrium, if it was with PGDA, and then to see if there is autoimmune problems, there is immunity problems, there is other things first to resolve and then to pass in egg donation. It's my opinion.
Okay, perfect. So we're switching orders around just to keep it fresh. So I'm going to ask Dr. Domínguez now. What would be your typical patient who comes along and you very quickly think, okay, don't go for one who's 46 or 47, but early 40s. How are they going to present that makes you think we should be having the egg donation conversation?
Usually repeated implantation failure or miscarriage, or with some miscarriage too or so. But especially if we don't have PGTA. But in cases of PGTA, even with PGTA, we use the repeated implantation failure, almost half of them. But after that and before that, we have to do some receptivity test, pneumatitis, hysteroscopy, something like that. But I think that most, even with euploid embryos, the pregnancy rate is lower in older than 40 patients. So
okay,
it's
sorry, go on. No, please.
No.
Okay, thank you. So last but not least, Dr. Bosch, I know you've got a lot of experience with egg donation and IVI and Spain in particular, lots of PGTA. So have you got a kind of, I mean, every patient's different, we know that, but have you got almost like an algorithm for saying, if I see all of this, we must be having the egg donation conversation? Can you give us a flavor of that?
Yeah, no, I mean, first thing that you need to know is the couple is able to produce viable embryos, and when we mean viable embryos, we speak about let's say fair quality blastocysts that are euploid, and if you don't have that, you don't have strong arguments to go to egg donation, right? Because the problem could be elsewhere. So first thing we need to know if the couple is producing viable embryos, and if it's not, regardless of age, regardless of ovarian response, then is when you have to talk about egg donation, right? Then now conversation comes at first point when the patient, when you see that the probability that you're going to have viable embryos is really low from scratch. I mean, if the patient has a low ovarian reserve and it's old, then we know that the number of eggs that she's going to need to have reasonable chances of have a viable embryo, an euploid embryo, are low. And then you need to put this on the table, on the discussion, and the patient, and they say, okay, example, we know that at 43, you need an average of maybe 20 eggs to have one euploid blastocyst, and according to her ovarian research, it's not going to produce more than 3 or 4. So that's a straightforward estimation of her probabilities, and then take the decision with her. And if she is ready to go for a small chance of pregnancy, then go for it. And but obviously, if she's not, you cannot recommend to go that, right? But it has to be a personal decision at the end. I mean, our role is to explain them where we are, what's the scenario, what are the chances, and help them on the decision. But it has to be a personal decision. We will see patients whose chances are really low, but this is they want to try, and it's okay. Let's go for it. And we'll see some patients in which her chances are reasonable, but they prefer to go for a more pragmatic approach and for a higher chances approach, and then you go direct to donation. You can have all the extremes at the end of the day.
Well, thank you. I think that's incredibly helpful to hear the kind of estimation. So a patient presents at 43. Obviously, patients are all different, but on average, it might take them 20 eggs to get a euploid embryo. I think that's really useful information, because then like you said, you can work out how many cycles. There's a cost to that. There's a time to that. And those are all things that people can factor into their decision, which I think that's really incredibly useful. Rather than, I mean, when patients come to me, I'm not saying they haven't been given all the information, but when they say something like, well, doctor said I could have another go, or I want to have another go, it seems to be lacking all of that extra information, which I think is very useful to help you make a decision. So thank you for that. So we've got another question, which I think is really important, because it moves away from the physiological stuff and more to do with the psychological. So it says, do your clinics have psychological support? And I would add to that also, not just support, but kind of assessment. That might be a part of it. When I worked in the US, we certainly did a sort of assessment for every patient who came through to see how they could cope with, going through ART during the egg donation procedure. And what do you recommend in terms of psychological support before, which I suppose is, getting to the decision-making process? So let's start with Dr. Domínguez this time. So psychological support for egg donation before and during and after.
Yes, of course. We have a psychologist in the clinic, because we know that for most of the couples, to resign around oocytes is a duel, and has some steps, and we used to send them to the psychologist to support during the decision, during the duel. And of course, we think it's very, very important, this support. And the patients usually give us a good opinion about this part. So they think they evaluate very well this kind of help in the clinic.
Okay, and in your own practice, and I'm going to ask the other doctors this too, but I'm asking this specifically because of Portugal. When you said that law has changed, as it did in the UK, much earlier, given that anonymity is not allowed anymore, does that change the psychology, the support, the counselling? What impact has that had?
I don't think so. I think that the change in the mind of the couple is before that. It's before facing that kind of problem, the problem about the anonymity or not. Maybe it's one of the points, but it's not for me the most important. The most important is to face the fact that it can be possible with it on all sides. And after that, I think it's a very important point too, but not the most at the first.
Okay, that's really interesting, because I mean, I'll give you an example from my own practice that I was counselling / coaching a patient who definitely needed and definitely wanted egg donation, and she absolutely wanted to go to Spain. I mean, she thought that was the best place, and I couldn't disagree with her that that was a good choice. But she said, "But I can't live with the anonymity thing." So you see what I mean? She'd got to the point where she understood, but she didn't want that.
Yes, in fact, for some couples, it could be very important. For example, we have some migration between the two countries. People who want to come to Spain to have an anonymous donation, Spanish women, especially women, but couple too that prefer to go to Portugal to have a non-anonymous donation. So, but it is in a very few number of cases.
Thank you. Dr. Bosch, do you want to add anything or say anything about psychological support, counselling, assessment of people, the psychological element, I mean, before egg donation?
Yeah, absolutely. Well, first of all, in Spain, is by regulation, clinics have to have someone for psychological support, not only for egg donation, but for any situation. But it's true that egg donation probably is the case in which it's more frequently needed. And yes, and there is covered many issues like origin of the donors, what are the motivations for donation, because at the end of the day, the psychologist that attends patients is the same one that is doing the psychological evaluation for donors, which is mandatory by law. And also very important to discuss, it is about disclosure in the future with the child. That's a hot topic that rises up in the consultation, the conversation, and the support of the psychologist for that discussion is really important for the couples.
So this is interesting because I know I've got some personal sort of connection to this. So you're talking about disclosure of the fact that the child was born from donation, but obviously the consequence in Spain is they can't by a normal method find out who the biological mother is, to use that term. But we all know with things like 23andMe and all these genetic tests, it's happening by accident, right? But you're saying just the act and fact of disclosure is a big topic, even though you can't find out, legitimately who the biological egg donor is.
Right. Yeah, and the recommendation that is always done from psychologists and from particularly in the UK, there are associations of parents of gamete donation. It's to normalize it. I mean, the way to go is not to wait that the child is 15 and then sit on the couch and say, look, we have to have a very important conversation and I need to tell you this. That's not the way to go. The way to go, it is when children are 5 or 6 years old and they start to make questions about how babies come, or even earlier sometimes, is just to tell them, look, babies can come like this way, and this way. In your case, it was this way. And they normalize it. They grow with that. They assume it. And it doesn't become a trauma at any point, right? And about 23andMe, I mean, this concern is there for several years already.
Yeah.
But at the end of the day, the proportion of people that is doing this kind of tests is not growing as is was expected initially, to the point that anyone can identify with his origin, right? So it seems that is going to take longer if it happens. Of course, if somebody doesn't know it is a donation and does this type of test, it's gonna suspect if it comes from different countries, of course, right? But so far, is not the point in which someone is going to find his donor by this type of test, because you will need a much larger proportion of population undergoing the test to have this possibility.
Well, that's really helpful. There's two really useful takeaways there. Even with this genetic testing, it doesn't seem to be a huge problem at the moment. That's a big takeaway that I'm getting from that. So and the need for disclosure, even in a country where donors are still anonymous, because people always say that in a non-anonymous situation, it's like they could find out anyway. But I do need to point out that even in countries where it's non-anonymous, UK example, it's not requirement to tell the child. It's the fact that the child is allowed to find out. So it's not quite the same thing, but it amounts to the same thing. So, Dr. Garavelas, can you say anything about the situation in Greece with respect to, how the psychological element is dealt with?
No, it's fundamental, not only for the IVF or for the egg donation. We use uh, counseling even for the maternity, because maternity also can change the balance of the couple. So it's very necessary to be helpful to understand the couple of what is the changes that can bring a child to their life. So even in IVF also, even in egg donation, and it's very important to us also because we have too many couples from abroad with different religions, different cultures, and it's very fundamental to understand and to feel the couple and to understand the couple what is very important for them. And my point of view, the importance here for the anonymous or not is that this the couple has the opportunity to have a baby that can change their lives, and this is the goal, and this is that must look at the first in at all. We talk about the forest, but we miss the tree. The tree here is to have an option to have a baby and to become parents. That they ask for us. They ask for our help. Okay, we are not magicians. We are only doctors and fertility doctors to help them. So this dream to have to become a parent and to have a baby come true.
Okay, perfect. Thank you. This we're going to move into a slightly different area of egg donation as a topic, but I'm going to use a specific question that's just come in, and then I'm going to generalize it. So let's stick with you, Dr. Garavelas. As I said, we're mixing the order up. Let's stick with you. So this question is, do you have, so this very practical question for Greece right now and your clinic and clinics you're associated with, is there a good availability of donors with blonde hair and blue eyes? So very specific, but then after you've all answered, I'm going to ask a more general question about the looks of donors. So please tell us what the availability is like. And by the way, you could just say yes, but say what your kind of mix of donors is would be helpful, please.
Everybody knows that in Greece we have the fresh donors, and of course we collaborate with banks of ovocytes, even from Spanish, even from other countries. The most of the donors are originally Greek or near Greece, so we are Mediterranean, and if you search to find how is it east of Europe origins, it's difficult to find it in Greece.
Okay.
With fresh donors, of course, okay, but we can collaborate, and we collaborate with egg banks, so we can have everything.
Okay, so that's thank you.
Okay.
That's a really important point. Just to reiterate, so if it's fresh, then you're somewhat limited by the demographic that you're embedded in. If it's frozen, pretty much have free reign to get hold of anything that's available, right? So let's go to Dr. Bosch. What's the situation? So blonde, blue eyes, but then more of an overview, please.
Yes. Well, I mean, as far as we are speaking about Caucasian phenotypes, we're fine.
Yes.
Obviously, we have more dark hair, brown eyes than blonde and blue eyes, but we also have more recipients that are hair and brown eyes. So it's proportional. I mean, at the end, the population is the same. It's just changing on age. So in general, we think Caucasian phenotypes we are ready to cover. Difficulties start with other ethnic groups, and particularly with Asians. Asians is probably the most difficult phenotype to find, mostly for cultural reasons, because it's plenty of Asians here also, but culturally donating is not as extended as it happens with let's say Western phenotypes, right? So for the moment, so far, we are able to cover because at the end of the day, as I said, the proportion of the phenotypes it's homologous, right, from donors to recipients.
Yeah, perfect. Thank you. And Dr. Domínguez, what's the situation in Portugal with availability?
It's almost the same than in Spain. We have, as Ernesto told, a mixture of the situations. But now in cosmopolitan cities like Lisbon, we have more opportunities to have this kind of phenotypes because we have Erasmus students that usually go to the clinics to do the treatment, to do the ovulation. So we have England women, especially East Europe women that comes and give us this kind of phenotypes. But in general, Portugal and Spain is brown hair, so it's less common.
And do you? I know Dr. Bosch mentioned it. A change. Do you have any limit on the number of cycles a specific donor can do, or on how many children or families they can produce?
The number of cycles. It's number of cycles too. Yes.
Okay. Okay. And what's the situation in Greece about cycles or babies born from a single donor, egg donor?
Is about babies born,
Right.
but the law is changed, and when we talk about abroad, we are more open to use for more babies.
Okay. Thank you. So I don't see, let me just see if I got any more questions in. I haven't got any more. Oh no, here we go. Okay. So what's your experience? Let's start with Dr. Domínguez now. Couple starts with egg donation and then they switch to embryo donation. So what is the trigger, which presumably means either there's a sperm problem and they could use sperm donation, or they go straight to embryo donation? Give us some scenarios where that might happen, please.
But usually, because the couples who do the switch is because there is a male factor, usually associated with a bad embryo development, and that in some cases it's a practical, very very few cases, is only about time. The couples where the woman is old, is very old, really 48 or so, and the husband too, and even there is not a male factor, they want to go very fast in the treatment and don't have any problem admitting this kind of situation. And in some cases, it's the price too, because the embryo donation is almost half the treatment of a donation.
Okay, so embryo donation is allowed, obviously, in Portugal, right?
Yeah.
Yep.
Yes.
So Dr. Bosch, can you say anything about embryo donation and sperm donation as it applies to someone already using egg donation, and its availability and permissibility in Spain?
It is. By regulation, the embryos have to come from couples that could be donors. The same criteria. I mean, a couple that has undergone IVF at 38 could never donate the surplus embryo. So both members of the couple would need to meet the criteria for being donors, right? But still, the availability is not high, but it's enough according to the demand. Obviously, most of the donated embryos come from egg donation cycles in which the couple already fulfill the reproductive desires, and then there are surplus embryos. And couples that ask for that option are, I mean, as you said, on one hand, couples that need gametes that are both donated. That's one scenario, and the other scenario is mostly financial, because the price of embryo donation is much lower than a full egg donation cycle, since the embryos are already there.
Yeah. Perfect. Thank you. And Dr. Garavelas, similar situation in Greece, or?
Quite similar. Even we have the conscious form that to donate the embryos, but in our culture it's very difficult to happen this. So we proceed with embryo donation when we mix the uh, egg donor and sperm donor. So we create embryo.
Yeah, okay, that makes perfect sense. So, Dr. Bosch, I'm going to come back to you because there aren't any more patient questions at the moment. Can you, without it being a sort of sale, can you talk about the sort of packages that you do for egg donation? Because that's been something I've had a lot of conversations with clients about, because they said, okay, I get this many eggs, or I'm sharing a cycle, and do you know what I mean? Just if you can lay out the kind of framework of what's available in terms of accessing donor eggs, please.
Yeah. Well, I can speak about our setting on the EB group clinics, but probably it's very similar to what many others are offering. So we have three programs, three packages. One which we call the basic program. It would be the donation. We're not speaking about the number of eggs, but the number of available blastocysts for transfer. So the basic program ensures or warranties embryo for transfer, but does not warranties surplus embryos for freezing. So it warranties the average number of embryos that we obtain with this program typically ranges around 2 or 3. And these are typically donors in which we only collected maybe around 8 eggs, 7, 8 eggs, 6 to 8 eggs, I would say. And then we destinate these donations to patients that are asking for this program, which is not the most popular one, but it is offered for couples that are interested, maybe single women only looking for one child, and since you're using sperm, also donor sperm, are good candidates for this type of program. Then the regular program is the one that warranties embryos for transfer and for freezing, and this is the regular egg donation cycle in which we typically try to collect on donors around 12, 14 eggs more or less, and this is what we get. So in these donations, most of the cases, the vast majority of the cases, we're going to have embryos for transfer and for freezing, average of 4 or 5 available blastocysts for transfer. That's the regular program, the most frequent one. And well, we also introduced quite recently the baby warranty programs. These are programs in which our patients pay an amount upfront, and then includes up to 3 full egg donation cycles with all the embryo transfers that could be generated from those processes, or warranties a baby. So what happens here is couples pay an upfront amount, and then either they have a baby, or if after 3 full egg donation treatments we didn't manage to achieve a baby, then they get this money back. There are certain inclusion criteria that need to be fulfilled for this, mainly avoiding severe and unsolvable uterine pathology or very, very severe male factor. Well, the fact is that this type of program has been accepted much more than I would expected initially. And currently 25-30% of couples are asking for this type of warranty program. So it's offered there then for any patient fulfilling all these criteria. So this is how we work in the EB group. I guess that most of the groups are offering similar packages.
Okay, perfect. Before I leave you and move on to the other doctors, can you just say what sort of, I know this is a bit of a how long's a piece of string question, but what kind of success rates would you be quoting for each of those programs? I mean, obviously the last one, don't say that one. That's it works or you get your money back. But the other two.
Yeah, for the basic, our cumulative ongoing pregnancy rate has been 70%, 70, because the average number of blastocysts that we're obtaining is by 3, so 2 to 3. For the regular program, the cumulative ongoing pregnancy rate is 84%. Here, the mean number of blastocysts that we're achieving is 4 to 5. And on the 3 egg donation program is 98-99% on the EB baby program. So I mean, it's up to 3 cycles, and with certain criteria, it is really exceptional that patients do not achieve pregnancy on those conditions.
Yeah, and is PGTA a sort of mandatory part of all of those programs, or not?
No. PGTA is not done regularly in egg donation. because in Spain, PGTA is not usually indicated below 35 unless there is some reason supporting it. So in egg donation, PGTA is not the rule unless there is some chromosomical issue on the male side, some structural anomaly that should be detected, of course. But as a routine, we are not using PGTA in egg donation cycles.
Perfect. That's really clear. I hope that's really useful for the listeners. Dr. Garavelas, let's ask you the same question because you may have different packages. So what are the packages and success rates, please?
Okay, we are similar in Spain in EV in the clinic. We not have different packages. We have the guarantee program also, and we have not only we guarantee 2 blastocysts for the transfer. And the program changes if the couple use freeze eggs or fresh donor, because with fresh donor we can give 8 to 10 oocytes. With freeze eggs, the couple is allowed to buy the package of the oocytes. And for us, we not use PGDA for egg donation only when we have some diseases, and only when we apply a request to the Greek authorities and have the confirm the case from them to proceed with the PGDA. So the percentage is very high. Is like EV is quite 80% in egg donation programs, and the guarantee programs is 99%. Is like for that reason is guaranteed. The difference, I don't know, maybe it's EV also, but we evaluate all the, of course, all the embryos in time lapse, and we have the artificial intelligence for scoring the embryos before the transferring. That we see that can improve the implantation rate.
Okay, perfect. Thank you. So same question to Dr. Domínguez, and because you've waited so patiently, you can talk about your Spain clinic as well as the Portugal clinic, okay?
Yes, it's more similar to the Ernesto talk, but we take into account very important things. The male factor there is a male factor too. For example, oligosteroteratospermia on fermentation, DNA fermentation very high. We can assure blastocyst. We only assign some number of oocytes. The couple can choose the number of oocytes that they want. If there isn't any male factor, we have the program to assure 1 or 2 blastocysts, at least 1 or at least 2, and for that we assign 5 to 6 for single blastocyst, and 10 to 12 for 2 blastocysts. And we have, of course, the guarantee program too, the Access Fertility. We don't use an proper program. We use Access Fertility. And usually we don't use PGTA for donors, for donation, except the cases where the couple switch to ovo donation because they don't have any euploid blastocyst. In some of these cases, the couple that want to do PGTA to the embryos because they don't want to, or they have some miscarriages. In this case, they prefer to have more possibilities not to pass again for the same situation.
Okay, perfect. I've answered one of the questions in the chat because I think Dr. Bosch already gave the answer, where it was someone who's 43 and saying, should I keep trying? But you gave a very nice statistic saying, if I wrote it down properly, 20 eggs to get a 1 euploid embryo, assuming 3 to 4 eggs per cycle. So you can very easily say how many cycles you need to do to get your 1 euploid. So although she didn't have it tested, could it be euploid? Yes, but low chance. So that's what have to consider?
I can show you a very recent example that I had a patient with, she was 41, but extremely low ovarian response. Indeed, we are doing modified natural cycles on her because we are unable to get more than one egg. But she was producing good quality blastocysts, and she preferred just to go for a fresh embryo transfer and not to submit the embryo for analysis. So we had this conversation and said, well, look, I mean, at your age, the probability of producing a neuploid embryo is around 25-30%, and the probability of this embryo, if it's euploid to implant, is going to be around 60%. So at the end of the day, each embryo that we are transferring is going to be around 15% of success rates. In other words, a sixth part. So this is like rolling a dice, and then the chances of having a number 6. This is your chances. So we can roll the dice every month if you like. And well, at the second embryo, at the second cycle, she has got pregnant. Of course, now we need to see how it goes on the first trimester. But second embryo that we transferred, implanted. Second cycle, we'll see if it's euploid, and it will have good chances of go farther, and we're going to see in the coming weeks. But what I'm saying is that it's not that you have to do always the analysis. If you assume what are the probabilities, and then just make your calculations and decide.
Perfect, thank you, very helpful. While I've got you, I'm going to ask you that tricky question I probably asked you before, but might have a different audience. Because we get into this conversation about everybody's different, age is just a number, we shouldn't hyper focus on the number. However, I think it is quite useful when you're speaking to a particular clinic and a doctor within that clinic to say, have you ever so far had success at age, whatever the age is? So what's the oldest age that you've had success at using own eggs?
46.
Okay.
We never managed at 47.
Okay.
Although still, I have to say that some patients, 47, 48, when you tell them, look, in 35 years you will be the first one, but some patients, they want to try.
Okay. And Dr. Domínguez, same question.
Yes, 46 too. It was a single woman, very probably from a family very, very fertile, very fertile. It was after one insemination, not in vitro fertilization.
But these are rare cases, right? I mean,
yes,
they're rare.
yes.
Yeah. And Dr. Garavelas, same question. It's not
Same
a competition.
No. I have 47 years old, but after ovarian rejuvenation treatments, I remember very well this couple because it was from the start of ovarian rejuvenation that came from Florence, and they didn't want to go with egg donation, so we tried. Say, okay, the situation here is bad, maybe there's no euploid embryos. And the first, we had three blastocysts, aneuploid, complex aneuploid, another cycle, 2 blastocysts, no embryos. I say, okay, maybe it's forget it. And the other round of IVF cycles, 3 embryos and 2 euploid embryos, and we transferred 2 embryos, 47 years old, and twins. So it was the first, and this is the maximum. But I don't know. It was from the start for the ovarian rejuvenation. Maybe it was something, or it was only the lucky one.
Okay, and thank you for that. And for the viewers or listeners, there's been some other sessions where we've talked about what can you do, if anything, to improve your ovaries as you age. So I recommend going back and listening to those to get a bigger picture, rather than just a one anecdote that was successful that will give you hope. It's okay to give you hope, but it's worth listening to the rest of the thing. So look, we're getting towards the end of the session. I don't see any more questions now. There's a big question, but we said we would contact that person separately because there's multiple questions in there. So I'm going to go round you all and just say, what are your sort of top 3 things that you think patients should consider before having egg donation? So I'll start with you, Dr. Garavelas, please.
I think the first and the most important thing is to become a parent and to be realistic. If they want to have they have, I don't know, some issues or low ovarian reserve or the maternal advanced age, if they want to have a baby yesterday, so realistic, they must try with egg donation. But is that the couple wants? Is very personally the question. I ask to all my couples in this kind of situation this question: if you ask yourself that you want to become parent, no matter what, so you know the answer.
Okay, perfect. That's actually, we'll stick with just one thing because that's easier for everyone to remember. That's really useful. It's like, think about what you really want. Is that how I'm converting that? Dr. Domínguez, what's the one thing that you would say to patients considering or going through egg donation? What's the most important thing to you?
Well, for me, is the willingness to be parents. So sometimes I have to talk because it's very difficult for them to talk about this situation with other couples to show how the couples who we work with have now are happy because they finally changed their mind and decided that to be a mother or a father is an emotional link, not a genetic link. So for me, it's very important to talk about these items with them because some of them change her mind after listening the experience by our board by listening the experience of another couples.
I think that's perfect information, perfect advice, because I know you three and most doctors I know who work in IVF have absolutely the best intentions for patients, but there's nothing like speaking to a person who's been through the system and understands it's from the inside, who doesn't have any particular vested interest. I think that's really useful advice. And I know some people who've been through egg donation don't want to talk about it, but I think there are plenty of people who do. So they're there, and you should reach out to them if you're considering it. Dr. Bosch.
Yeah, I agree with my colleagues, and I mean, I have seen so many couples that put themselves all the imaginable barriers for going through, and but at the end of the day, when they do it, and as soon as they see a 5 mm embryo with a positive heartbeat in the ultrasound, so it's not even needed to deliver, but just at that point. And maybe patients that have been a couple of years trying with raw eggs, and then they tell you, I should have done it before. And then say, well, but you were not ready, so don't blame on you anymore, right? And then you still made it, right? So I have seen so many couples that they come afterwards with the baby, and I particularly remember one patient telling to me, look, it maybe does not have my eyes, but it has my look, and that's, I think that summarizes the whole thing. The link that it is developed during pregnancy and during delivery and during the very early days of and months, it's so strong that all the barriers that were there before taking the decision completely disappeared. And I think that for those patients that are in that situation, that are not, I mean, not really ready to take the move, it's fine. That's the right thing to do. It's a process, but what we can say from the bigger picture and from seeing the patients before and after, they don't regret. Sometimes they tell you, just we should have done it before.
Perfect. Thank you all so much. That's really nice note to end on. I think all three doctors gave a really nice, one tip for you to take away. And I suppose the only thing I would add to that is to say, given all of those, given that tension and difficulty in making the decision to go in this direction, it's clear that we need to give as much support as possible from clinics and outside of clinics for patients who are in this situation, because we don't want people regretting and saying, I wish I'd done it earlier. We want people doing it at the right time for themselves. So only leaves me to thank the audience for being here. Thank you for turning up so regularly and asking all your great questions. Thank you so much for our panelists this evening. And thanks to My IVF Answers for putting on Ask Your Doctor. And I hope we'll be doing this again in the near future. Thanks, everybody. Good night. Bye-bye.
Bye.
Thank you.
Good night,
Sure.
Alan. Bye bye.
Good night. Bye.